Hey, if you don't know me, I'm Dr. Stout, one of the anesthesiologists with Jackson Anesthesia, and I was asked to give an in-service on malignant hyperthermia. This is one of those things that's, you may see once in your career, estimated between like 1 in 5,000 to 1 in 50,000 cases that you do. So usually, an anesthetist or an anesthesiologist will see this once. And so it kind of becomes one of those things that you know it's a big deal, but you almost forget about it if you don't go through it fairly frequently in your mind, because it's about 80% mortality rate if it's untreated or treated incorrectly. The funny thing about MH is that there is a genetic inheritance pattern with it. It's autosomal dominant, but it has variable penetrance, meaning that it's just very variable in the population. So about 50% of MH susceptible patients have had an uneventful general anesthetic in the past, which is pretty incredible. The gist of MH is intracellular calcium homeostasis gets just totally thrown off. Usually this happens through two cell or two receptors, either one on the surface of the cell, which is a dihydropyridine calcium receptor, or it's a receptor on the surface of an organelle inside the cell called the sarcoplasmic reticulum, and that's the ryanodine receptor. An alteration in one of these receptors is ultimately responsible for this whole problem with MH. And basically you just get a ton of calcium released into the cell that's not normally there. And then the cell goes into overdrive trying to push out this calcium, and so you're generating a lot of heat and using a lot of ATP, so a lot of energy. And so the depletion of ATP plus the heat causes these cells to die, and then you spill out all the bad things like lactic acid, potassium, phosphate, and this kind of leads to the sequela of MH. So that's kind of a very dumbed down gist of what's going on with MH. Things that trigger MH, the only things that we know trigger malignant hyperthermia are the volatile anesthetics, which is sevoflurane, the yellow gas on the anesthesia machine, isoflurane, which is a purple gas, desflurane, and halothane. Those are volatile anesthetic agents, and they are triggers. And then the only injectable medication is succinylcholine. All other anesthetics are non-triggering. So you can use nitrous oxide, it's non-triggering, and then all other injectable anesthetics are fine to use. Things that are conditions that are high risk, there are certain genetic conditions that increase the risk of malignant hyperthermia, and they're central core disease, multi-medical core disease, and King-Denborough syndrome. There are probably others, but these are the three that when we're putting people to sleep, if they have any history of that, that's what we worry about. There's some people that have this misconception that Duchenne's muscular dystrophy is associated with it, and it's kind of its own reaction to succinylcholine, not really an MH per se. So how to prevent it? They used to recommend pre-treating with dantrolene. That's no longer recommended. The way to prevent this is just to avoid any kind of triggering agent in anybody that's got an elevated risk of MH, family history, or has any of these syndromes that have previously been mentioned. Generally, if you have an MH susceptible patient, you have to flush the machine. You got to remove the vaporizers. It's usually 20 minutes, 10 liters per minute of O2. Although some of the newer machines, like you guys have here, like Drayers, that have a lot of plastic and rubber gaskets, can need to be flushed for like 60 minutes because the plastic and rubber pieces actually serve as a reservoir for the gas, so it'll trap gas, and it just takes longer for them to blow it off. Signs and symptoms. So MH is essentially just a hypermetabolic state. So you get elevated heart rate, elevated respiratory rate, elevated temperature, rigidity, sweating, tea-colored urine. All of these are kind of the signs that you'll see, elevated end-tidal CO2. And then laboratory data is kind of like what we talked about earlier. When the cells die, they spill calcium, potassium, lactic acid. You'll have elevated serum and urine myoglobin. So all of these are signs, but it's really, for the anesthetist, whoever's taking care of the patient, an unexplained rigidity with all of these signs is your cue that, hey, this is maybe MH. So the treatment's supportive. You want to immediately call for help. Tell the surgeon or the proceduralist, whoever's doing the procedure, hey, look, we got to stop or finish this up as quick as you can. You're going to need a lot of help with this because dantrolene, the treatment, it's very cumbersome to mix up. There's two different formulations. There's Dantrium and there's Ryanodex. Dantrium comes in 20 milligram vials, and you're going to need to mix this with 60 cc's, each vial with 60 cc's of sterile water. And there's about 6 to 10 vials that will need to be mixed up for the treatment of one patient. The Ryanodex or Ryanodine is basically a super concentrated mix of dantrolene. It's about double the cost of the traditional treatment, and it comes in 250 milligram vials that you can reconstitute with 5 cc sterile water. So you can imagine that's a lot easier to give, it's a lot quicker, but it's also much more expensive. So aside from dantrolene, like we said, it's supportive therapy. It's fluids, diuresis to try to keep the urine output 1 cc per kg per hour. You're trying to cool a patient, so ice packs, cold saline. And then obviously this is going to be kind of a chaotic situation if this happens. There is a dedicated 24-hour-a-day hotline for malignant hyperthermia. There's somebody that will answer 24/7. So usually what you do is you start your treatment, then you call somebody and they will walk you through the steps of treatment. And I'll put the number on your handout. There's also a link that you can click on if you're interested in learning any more about malignant hyperthermia. And that's the completion of this talk. I'm happy to answer any questions if anybody has any.
I have a question.
Sure.
You said hyperventilate with 100% O2.
Yeah.
It comes through the anesthesia machine, so
Yeah.
you switch it to the wall instead?
So you would basically just take the vaporizer off, and if you have activated charcoal filters, which I'm not sure if we have here or not, you'd put filters on, or you could also try an ambu bag with the wall output, but essentially just trying to get whatever gas is getting to them away. The quicker you flush it out, the quicker you can stop their body reacting to the gas. All right.
Thank you.
You're welcome.
Thank you.